Hi, this is Dr. Adrian Lopresti. Join us on FX Medicine next week, where we'll be talking to Dr. Paul Clayton about the increasing popular chemical known as palmitoyl ethanolamide, otherwise known as PEA, and how it can be used to help treat a range of health conditions. Subscribe to us on your favourite podcast app and follow us on social media to make sure you never miss an episode. Hi, and welcome to FX Medicine, where we bring you the latest in evidence-based integrative, functional, and complementary medicine. FX Medicine acknowledges the traditional custodians of country throughout Australia, where we live and work, and the connections to land, sea, and community. We pay our respect to the elders, past and present, and extend that respect to all Aboriginal and Torres Strait Islander people today. Joining us today is Dr. Simon Rosenbaum. Simon is an academic exercise physiologist and associate professor in the discipline of psychiatry and mental health at the University of New South Wales. He is also the president of the Australasian Society for Traumatic Stress Studies, co-chair of the Olympic Refuge Foundation think tank on sport and humanitarian settings, and an associate professor of the journal Mental Health and Physical Activity. Simon's research focuses on physical activity, trauma, and mental illness, and he has published more than 230 peer-reviewed publications in the area. Simon is also the founder of Addi Moves, a physical activity and lifestyle program targeting women from refugee and asylum seeker backgrounds. Welcome to FX Medicine, Simon. Thanks for being with us today.
Thanks so much for having me.
No, it's great. So certainly today, I wanted to talk a bit about your expertise, obviously in the exercise area and the mental health area, and how they kind of work together, and how exercise can potentially be a treatment and a preventative, I suppose, for mental health conditions. But you've trained as an exercise physiologist. So can you tell me a bit first about, firstly, what is an exercise physiologist and how does it differ from other kind of professions in the similar area?
Yeah, very, very common question. So exercise physiology is one of these newer allied health professions. So that's probably the important point to note, that they are allied health practitioners. And essentially they're trained in the use of exercise to support recovery from or management of particularly chronic disease. So a lot of work with things like cancer, diabetes, metabolic syndrome, cardiovascular disease, really reflecting the evidence that we have around the benefits of physical activity and exercise. Mm-hmm. So EPs can be found in clinical environments, in hospitals, in GP clinics, workplace rehab, sort of a variety of different settings.
Okay. And do many work in the mental health field, or like yourself, or are there many in that area, although there's other areas that they particularly work through?
Yeah, now they do. I mean, it's really exciting. When I first started, so when I did my training, which would have been I started in 2006 at UNSW, mental health wasn't something that was really covered in the program at that point. So I don't think there was a lot of work available specifically around the idea of mental health, exercise physiology. But internationally, not just here in Australia, over the past sort of 15, 20 years, there's been a big shift around that. And that's obviously due to the evidence base, which has emerged around the benefits of exercise. So the opportunities that have come across the whole spectrum of mental health, if we think right through from inpatient forensic mental health unit here at Prince Wales Hospital, all the way through to, maybe community health centres where mental health and mental illness is a big factor. There's now lots and lots of work. And I think now it's one of the areas where we have the most EPs working in that space.
Oh, wow. And so how did you get into the mental health area?
Totally by chance.
Okay.
So, yeah, I wish it was a different story. But look, I was doing my undergrad, and I knew someone who worked at a private psychiatric hospital in finance. And he gave me a ring one day and said, do you want to, we've got this gym here that's shut. Do you want to come and open it up? And so I thought that sounded a bit interesting, and I had no idea what to expect at a mental health facility. I had no training in mental health. And so I turned up with the bias and stigma that anyone else would if you're not familiar with this area, and started opening this gym. And the people that were coming to the gym were from the PTSD unit, the post-traumatic stress disorder unit. So a lot of veterans, a lot of emergency service workers. And I just kept seeing the same story unfold and hearing the same thing, which was people saying how important exercise was for their own recovery. And for many, particularly, these were a lot of young men, that exercise really played such a pivotal part, but there was very limited, if any, funding or recognition of that. And so that was how I then got involved in research, because, for me, it was about, well, how do we change that? How do we raise the profile of this? How do we increase access? And so that was when my interest in saying, well, we can generate that evidence to try to change things. And that was how I ended up doing my PhD, looking at exercise and PTSD in the inpatient unit. And then it sort of went from there.
Wow. And certainly you've published extensively in the area. So, thank you for all the work that you've done. And I've read lots of your papers over the years, educated myself basically, and become more informed about the importance of exercise and physical activity for, with my clients. So thank you.
No, it's great that it's being used. I think we've been really lucky, and it reflects the international recognition of this. So I've just been lucky to be one part of that.
Yeah, no, great. Now, I've got a question. I've read a little bit about your work with a project called Addi Moves. Can you tell us a bit about what Addi Moves is?
Yeah, so this is something that I'm really excited about and really grateful to be able to talk about. And it's essentially a culmination of all the work that I think I've been involved with over the last 10 or nearly 15 years. Addi Moves is a program that we've set up at the Addison Road Community Centre in Marrickville in Sydney. Mm-hmm. And that community organisation has been around for a long time, primarily dealing with food security. So they feed about 8,000 people per week through the food pantry. They also have a range of other social services on site that are co-located. So you've got Marrickville Legal Centre, you've got domestic violence services. There's a whole range of different social services. We, in 2022, got given a building out at Addison Road Community Centre to set up what we called Addi Moves. And essentially, Addi Moves is a free, trauma-informed physical activity service for people that are experiencing social disadvantage or exclusion or have been exposed to trauma. So the sort of populations that we're focusing on are people from a refugee background, people that have experienced some sort of gender-based violence or sexual violence, people that are food insecure, so reliant on the food pantry. So a whole range of people that are experiencing what's sometimes termed intersectional disadvantage. Often people don't just fit into one of those categories, they fit across all three. And the idea being that we know exercise and physical activity can be so important, but actually it's those people in the community that are completely excluded from existing programs. If you can't afford shoes or you can't afford healthy groceries, the last thing you're probably thinking about is going to exercise. But what we know is that if done in the right way, in the right environment, there's actually so many things that exercise can do in a supportive environment to actually help people, and not just with their mental health, but also with their physical health.
Wow. So what type of exercise do they do at the centre?
Good question. And this I can answer with the evidence, is that it doesn't matter, actually.
Yep.
So the type of exercise is not important. When we talk about the mental health benefits, what's really critical is thinking about how do we actually support someone to participate in an activity that they enjoy, that's culturally appropriate for them, that they feel safe doing, that they want to continue doing. That's the biggest challenge. So in other words, what we're talking about there is building what's called internal or autonomous motivation. So we're helping someone to recognise the benefits, to feel the benefits for themselves, and then to participate and provide the means by which they can do that. So the most important thing there is that we actually create this safe environment that meets the needs of these people so that they can come, and then the actual exercise program is kind of the easy part. Because once we get those other factors right, the type of exercise really doesn't matter. It's about doing something, a mixture of aerobic and resistance-based exercise, but again, coming back to the individual preferences of that person, what they enjoy, what we can help support them to do.
Yeah. And so can they drop in at any time of the day and kind of engage in exercise, or is it classes? How does that work?
Yeah, so we do have a booking system, obviously, and it depends on how long we're working with people for. So we've obviously got to be careful that we're not just creating something where people are dependent. So we're trying to create skills so that people can also then take those skills and maybe find other options where they can participate. It could be local facilities, or it could be home-based programs. It could be just stuff done. We don't have to be in a gym in order to exercise or to get the benefits from movement, but it's about giving people the confidence, the understanding, the knowledge, and the skills that they can actually then take that themselves. And hopefully we're sort of aiming for sustainable long-term change as opposed to a short-term program.
Great. And are you getting people that keep coming back and keep returning to the facility?
Definitely. I mean, we've had some really amazing stories, and we're very fortunate. We've got an incredible team of exercise physiologists. Kiara and Uzma are out there at the moment, and they're doing some great work with the community. And we're getting some really incredible stories of people that have experienced really, horrendous experiences along their journey to Australia. So refugees and asylum seekers. Also people here living in very difficult situations with, again, that social exclusion, the marginalisation, and just the cascade and the impact that has, poverty on health outcomes, and how that actually something like this, where you're giving someone a space where they can come that is safe, that is welcoming, that's happy to listen to them and offering something for them, can actually be really powerful. And the other thing that we're finding is that this sort of program can be a soft entry into other services. And this is, something that we've done a lot of work overseas as well, finding the same thing, that, attending mental health services can carry stigma for some people or certain groups. Coming to, kick a ball around or do some exercise or be in a dance class doesn't necessarily have the same stigma. And so there's this idea that, yes, we should be putting physical activity programs in, mental health services, but also flipping that the other way and saying, well, how can we put mental health support and basic services inside areas and programs where people are actually coming, which could be community sport-based or physical activity programs like this? And how can we then utilise that as a way of linking people to the other services that they may need?
Yeah, no, that sounds great. Well, I think, as you're talking, I'm thinking, certainly you're right. The stigma associated with, for me, I'm a clinical psychologist, so often there's a stigma associated with potentially coming to see me. But if you're then looking at going to a place where you're just, you're engaging in exercise, and it sounds like it's more than exercise. It's a sense of community and support that you're also offering too. So I can see how it would be great for a whole range of different people, young children and teenagers and men who are kind of reluctant to seek services. I think there's a great opportunity there.
Definitely. And on the same note, it's if you think about exercising or going to a gym, I mean, I literally study this, it's my job, and I find gyms, very intimidating places. I've got one at the end of my street and I don't love it. It's not somewhere I enjoy being. And so if we then think about, if that's the baseline about where some people are, if we then, compound that with some of these difficulties that a lot of people in the community have, or, even minor mental health symptoms, whether it's anxiety or something similar, that can be a real barrier to actually having a place that is safe, that's welcoming, that you can actually go and participate. Yeah. And so for us, it's this critical point about, we've got to stop just telling people you need to exercise for your health, and actually start going, well, how do we support people? What's actually needed? What are the actual barriers that's facing people? Yeah, absolutely. No, I agree with that. I've certainly seen over the decades the changes in also the environment. I do go to the gym, and I noticed that when I first went, it was very social. Nowadays, you're putting on headphones and it's very isolated. You're not talking to anyone. So I agree that we need to look at other ways of delivering physical activity. So that's great. Now, you mentioned refugees. So obviously a lot of the refugees are experiencing trauma and PTSD. So what's the research around exercise and PTSD or post-traumatic stress disorder or in trauma? Yeah, so the strongest evidence we have around exercise and mental health is really around depression. We've got lots and lots of trials around depression. Every couple of weeks we have a new meta-analysis with another effect size. So there's numerous studies there. We've got some strong evidence as well for anxiety or generalized anxiety disorder, also for schizophrenia. PTSD has got relatively less evidence. There's relatively fewer trials. However, we still do have good data showing that exercise can be an effective way of minimising PTSD symptoms. And that's now branching out into sort of diverse populations of trauma-exposed groups. So there's great work happening in the US, particularly with veterans. So there's a great researcher there, James Whitworth, doing fantastic work around physical activity in veterans. Equally in people that have experienced sexual violence or gender-based violence, there's lots of great work happening in that area. There's obviously different considerations if we think about exercise programming or how we would set up and run an exercise service for people that have experienced trauma. So there are, unique differences there, but the evidence is there. So really there's a good amount of data, and particularly what we know about the impact on other mental health conditions, but also the impact that we know on comorbidities associated with PTSD. So, for example, the diabetes, the metabolic syndrome, that are all consequences of long-term PTSD. There's good data suggesting that if we actually intervene early with lifestyle factors, by addressing these lifestyle risk factors, so things like sedentary behaviour, physical inactivity, poor nutrition, smoking, that it can not only improve the physical health outcomes, but also have an impact on mental health outcomes as well. Wow. So, the data is there. It's still, if we look at clinical treatment guidelines, they're still often, they don't quite consider physical health or things like physical activity, but we're slowly getting there, and the recognition as the data builds is increasing.
So is there any research, so you mentioned kind of, there's some preliminary, obviously, research showing beneficial effects on PTSD. Is there particular types of symptoms that it works specifically for? Like, does it improve sleep? Does it improve, does it improve mood? Does it have an effect on, I suppose what I'm thinking is, it may have a beneficial effect because it improves sleep. Does it have any effect on ruminations and things like that? What are your understanding of the research there?
It's a really good question. So essentially, we've got some data around all different symptom clusters. So if we think about re-experiencing avoidance, there's a bit of, again, it's preliminary studies looking at the relationship between those symptoms and levels of physical activity. So there's cross-sectional data. But as you pointed out, in terms of the intervention research, it really depends, and it depends on the population group. So we do have some evidence from trials that exercise can improve sleep quality. We've also got some evidence directly looking at PTSD symptoms, some looking at depression, some looking at anxiety, some looking at physical health. So it's really, it's a bit of a hodgepodge. But if we sort of take it all together, the overall recommendation is that physical activity can be a beneficial component of treatment. Yeah. So I think it's important that when we talk about the evidence, including with depression, that we're very clear in that exercise can be a first-line recommendation for mild to moderate symptoms. And for some people, it may be enough, but we would never say that exercise can treat PTSD by itself. In the absence of evidence-based psychological treatments. And I don't think there's ever going to be a situation really where you would be advocating for that, because what we're actually saying is that this should be another tool in someone's tool belt. And that's what the evidence seems to support, that if someone's receiving best practice PTSD treatment, it includes exercise as part of that. And that may be addressing the sleep issues, it may be addressing some of the other symptoms, but it's a component of care. There's still a bit to do around unpacking that relationship a bit further. But I think one of the difficult things when we try to understand or talk about the mechanisms or what exactly is happening is thinking about where someone is in their recovery journey and what else is happening in their life. So, one of the stories I remember from someone that participated in one of my studies was an older gentleman, a Vietnam vet, and who was completely socially withdrawn, had a whole bunch of issues with his relationships. After participating in an exercise program, he then started walking again. And because he started walking, he then realised that maybe he'd go back to playing golf. And that then triggered him reconnecting with some of his mates, which had a big impact on his social relationships and then his impact with his wife as well. Now, of course, we're not saying exercise then had the impact on his relationship with his wife, but you can see that cascade that it triggered. And by helping people regain control over their physical health and re-engage in some of these sorts of programs, it can have all sorts of consequences.
Yeah, and that's what I love about, I suppose, lifestyle psychiatry is that, it's not just one component. We're not just necessarily relying on one intervention. And I think there's danger in any practitioner just relying on one intervention, whether it be exercise, whether it be even psychological therapy, whether it be pharmaceutical medication. We need to look at, what tools do we have available to us, and certainly exercise is one of those. And I agree that, potentially it can lead to other changes in other areas. And I suppose, I don't know whether there's been any research, but, does people who engage in exercise from a mental health perspective, do they also change their diet? Even though it may not necessarily be targeted, would that change? Would they interact more? Would they?
Yeah, it's a great comment, and that's why that term, lifestyle psychiatry, it's sort of, they all come together, because ultimately, we work closely here with Dr. Scott Teasdale, who's a mental health dietitian. He's done some fantastic work in that space.
Yep.
And they go hand in hand. We don't need a dietitian to say to someone, hey, let's drink a little bit less soft drink and try to eat more vegetables. Mm-hmm. Just like we don't need an exercise physiologist to say, hey, try and do a bit more activity. But what we do need is to match the resourcing to the need of the individual.
Yeah.
So if we've got someone with really severe symptoms, they're going to need more support to actually change their diet or to change their exercise. And so we can't just expect that simply saying, hey, go and do this is going to have an impact. And that's where I think sometimes we fall over, is that we're just not, or we say that these sorts of lifestyle approaches don't work. What we're actually doing is not providing a dose of intervention that's sufficient for that individual.
Yeah, absolutely. I agree with that 100%. Now, what about, so we're just kind of going back to trauma. So people with, who have experienced trauma as children or have experienced adverse childhood experiences, can exercise potentially minimise the likelihood of them developing mental health conditions in the future? Is there any early intervention stuff that's been done?
There's some really exciting data that's come out of the UK, and another review out last year showing that young people that have been exposed to adverse childhood events, participation, particularly in team sports, appears to be protective against future mental illness down the track. Now, I think there's lots of reasons to sort of be optimistic about that or to be interested in that finding. And one of them is it this idea that team sports, we know there's a social environment, but also potentially the impact on physical health. And if people are participating in team sports and they avoid that drop-off in activity and therefore increasing sedentary behaviour, does that potentially protect against future mental illness? And we've got other data in depression, some great reviews looking at incident depression, incident anxiety, that physical activity is protective. So again, this idea that we should be promoting physical activity, not just as the idea that this is a treatment, but also that maintaining activity levels can help protect us against future episodes of poor mental health.
Mm-hmm. Yep. So much the same as, I suppose, the research around exercise and physical conditions and the potential prevention of diabetes and cardiovascular conditions.
I think with the ACEs, what's interesting is if we consider things again like poverty, social exclusion, disadvantage. Where are the programs and services to keep people engaged in activity? I know there's great examples, but I don't think they're as widespread as they could be to really think about sport and activity as a way of supporting people to really engage in those behaviours long term, and what's going to be needed to keep that to happen.
Yeah, absolutely. I suppose one of the other things that you also mentioned was the fact that a lot of people with mental health conditions also have comorbidities, physical health comorbidities, whether it be cardiovascular diseases or metabolic conditions. So with that, so if somebody's presenting with depression or anxiety or even, you mentioned even schizophrenia. So the exercise, I know that there's some research showing that the exercise has beneficial effects from a mental health perspective. What does it do from a physical perspective? Does it help also improve their physical health? Are we seeing some long-term improvement in their physical health and prevention of reduction in mortality and morbidity and things like that?
Yep, absolutely. And look, I don't want to sound like I'm just saying exercise is going to cure the world of everything. It absolutely won't. But you're spot on, and the physical health of people with mental illness is a critical issue and something that's been described as a scandal globally as an issue that is ignored. We know that on average, people with serious mental illness, so we're talking schizophrenia, bipolar, major depression, have a reduction in life expectancy. And depending on what data you look at, somewhere between 10 and 25 years is the numbers that are often cited. And that that gap in life expectancy is not due to suicide, it's due to premature cardiovascular disease. So this idea, and this has been described as a scandal, or the scandal of premature mortality. If we talk to people in Australia about closing the gap, we rightly so recognise that we're talking about Indigenous Australians and the absolutely unacceptable gap in health outcomes facing Indigenous Australians. That same gap is there for people with serious mental illness. Now, what's equally as frustrating in that is that it's not a lack of knowledge around what do we do. It's a lack of resourcing around implementation to be actually doing the things that we know works. And I can give you an example. A great project that I was involved with, led by Professor Jackie Curtis, it was called Keeping the Body in Mind, and looked at young people experiencing their first episode of psychosis. What that program looked at was the impact of medication that we know is really important from a mental health perspective, but has a devastating cardiometabolic consequence. So these were young people, their first episode of psychosis. We had two groups. So one group who got access to this program that was called Keeping the Body in Mind, and that involved an exercise physiology program, a dietetics program, a clinical nurse consultant, and a peer worker, providing this holistic from day one as soon as they initiated medication. And then we had another group who was a control group who didn't get access to that program. And what we showed was that the control group on average gained about 7.8 kilograms of body weight within the first 12 weeks. Now, that's entirely consistent with what the evidence tells us normally happens with these medications. And so what we were able to demonstrate with that Keeping the Body in Mind program was that with that intervention group, they had a non-significant increase in weight over that 12-week program. Now, we published that, and that was enough for the district here at South East Sydney Local Health District to roll that program out across 3 sites, which then provides the recommendation. And there's new data now showing that the benefits of that program were maintained at 2 years. And so it speaks to this idea of this critical period within mental health treatment where physical health deteriorates rapidly. And if we intervene early, as soon as we can with physical health, then we're likely to not only improve mental health outcomes, but also protect and promote physical health and well-being. And although that's in psychosis and as a different group, I think the same principles can apply to depression, to PTSD, to anxiety. As soon as someone is seeking help for a mental health issue, we need to be considering physical health at the same time, because it's likely that physical health markers have already deteriorated.
So were there differences in mental health outcomes between the two groups too?
No, it's a good question. We didn't look. So this was a pragmatic evaluation that was done in a community mental health centre at a hospital.
Okay.
So the mental health measures that we could take were routine measures. We couldn't do clinical interviews or things like that, given the nature of that evaluation. However, there is good data around the impact of exercise on symptoms of schizophrenia. So the European Psychiatric Association released guidelines in 2018 on physical activity and serious mental illness. There's recommendations in a Lancet commission that was published in 2019 on exactly this topic, protecting physical health in people with serious mental illness. And we're actually updating that commission at the moment, which is really exciting. Even though it's only a few years later, there is so much new evidence that has come out since helping to guide that implementation.
Yeah, wow. Has there been any research on, like if let's say with an adult, you place them on an antidepressant or you place them on an antipsychotic, does it prevent weight gain potentially from the medication or improve physical health outcomes?
Yeah, one of the issues is around measurement, because if you're an adult that may have been, let's say, in and out of mental health treatment, then chances are that by the time a project like this would capture your data, the damage has already been done. Yeah. And so it's very difficult to capture. That's why we were focusing on youth with their first presentation, because that way we can really actually capture the dramatic consequence. I mean, it's not unusual, and I'm sure you've seen the same, but we've seen, numerous cases of people that within, a 12 to 15 month period have put on in excess of 100 kilograms of body weight associated with certain antipsychotic medications. And again, medication that's important, but that just really has this dramatic physical health consequence that we need to be trying to prevent.
Yeah, I mean, obviously you've got then the changes in physical health, the increase in weight gain, the inflammation that results, the potentially they're now becoming self-conscious and not interacting as much. They're therefore
Exactly.
withdrawing. There's a whole gamut of kind of areas, and then potentially then stopping the medication and
Exactly.
um, and
Yep.
possibly relapsing and often if you're experiencing weight gain and the negative effects from the medication, many people go off it abruptly and relapse. And so it
It's
just
a
makes
cycle.
sense, doesn't it? We just really have to include exercise. So do you think it's becoming more recommended from practitioners, from mental health practitioners in terms of exercise? Do you think GPs are going out there and somebody coming in with depression, they're recommending as a part of the intervention that they engage in exercise? You think that's happening now?
Definitely. I think, I'm really optimistic and seeing lots of changes. I think there's still a challenge there's a couple of challenges from that workforce side of things. And this is an area of my research that we're really focusing on at the moment, which is how do we build physical activity capacity within the mental health workforce? And equally, how do we build mental health capacity within the physical health workforce?
Mm-hmm.
And we're doing this not just in Australia, but also in refugee and humanitarian contexts where you actually don't have a really strong mental health system. So you have to then think about how do we utilize sports coaches or PE teachers who are doing something that might be effective. They just need some skills about how they can make that safer and more welcoming for those people. So I'm really optimistic. I think the challenge that we have here in somewhere like Australia is how do we make it as easy as possible and how do we utilize existing referral pathways? So I think, one of the somewhat frustrating things is that we have one of the most advanced lifestyle and allied health referral schemes in the world. There's not many places that you go where if you turn up to your GP under Medicare, you can get up to 5 sessions with allied health providers.
Mm-hmm.
So that can include a dietitian, it can include an exercise physiologist. So the criteria for that is essentially chronic disease or chronic disease risk factors. So mental health absolutely would count. And so if you've got someone who meets that criteria, they could be referred now under the existing infrastructure to sessions with a dietitian, with an exercise physiologist or a physio.
Mm-hmm.
It's not well utilised, so it's getting better, but it's still the utilisation and referral rates are very, very low. So I think there's still an issue here about how do we make it as easy as possible for these referrals to take place. The other thing, if we think about our mental health system, it's completely overburdened. We know that most people don't seek help, and of those that do, there's enormous waiting lists, etc. But if we have these workforces like dietitians, exercise physiologists, that in the meantime, while someone's on a waiting list, could be referred there or could also be seeing those health professionals. Sure, we're not going to treat everything and we're not going to then say, well, we don't need the mental health service. Absolutely not. But what we are likely to do is to reduce the burden somewhat, improve outcomes, and at the very least, improve physical health. So I think there's for me, that's what I'd love to see in the future. Someone calls up or makes an appointment with a mental health professional, and immediately there's a referral made to a physical, health person, the dietitian, the EP, who ideally may even be co-located within the clinic.
Yeah.
So that's something that I think in the future where we it would be great to be heading towards.
I think that's also where there needs to be a bit more, I mean, from my perspective, and I don't know whether it's generally, but there needs to be more understanding about what exercise physiologists do, and there is that potential danger where you think you hear the word exercise, and somebody with depression, for example, then thinks, "Oh, wow, now you're going to kill me. It's going to be, at the gym lifting weights and you screaming at me and that type of thing," which can be very intimidating and obviously incorrect. But we obviously need to inform practitioners and the consumer what an exercise physiologist does and what the experience would be like.
Yeah, that's a great point. It's absolutely critical. And we have, even the word, it's a bit of a dirty word, isn't it? Exercise for a lot of people. So it's not a great title. I'll be honest with you there. But, really the simple way of explaining it is that it's actually just supporting people to be able to move their body in a way that's safe, enjoyable, and effective for them. I think that's probably how I would think about it. And even, the term, we're moving away from the term exercise around the mental health space towards movement because of the negative connotations and also the there's a lot of issues with online social media and influencers and exercise is a tricky thing. So yeah, I totally agree with you there. It's something that the branding and the marketing needs some work, I think.
Yeah, I think you use the right term there, movement. I was just thinking physical activity physiologist doesn't sound that great. So there needs to be something different to that. Okay. Now, saying that, obviously not everybody's an exercise physiologist and potentially, as practitioners, we're seeing somebody come in with mental health conditions, whether it be depression, whether it be anxiety, whether it be a history of psychosis. It can only exercise physiologists recommend exercise?
No, definitely not. I think there's a great program in the UK called Making Every Contact Count. And it was a big push from a group over there around physical activity and talking about the importance of every health professional using every contact possible to reinforce the message of how important activity can be. So I think everyone has a responsibility, and a lot of the work that we've done here with the mental health workforce has been actually providing interventions to them where we actually try to get them moving and engage in an exercise program themselves so that they actually understand and can better talk to patients. So I think that's really critical. What I sort of answer that by coming back to is that idea of the resources matching the needs of the individual. Now, so if we've got someone who has a number of risk factors, so if we're talking someone that maybe has a psychotic illness or, significant weight gain, diabetes, a lot of potential factors that might make exercising a bit tricky or potentially have some contraindications, then I think it's important that there's a health professional involved, like an EP or a physio supervising that program. But even to that person, we can be talking about, have you tried moving a bit more? Can we try to, hop up off the couch or go for a walk or walking for 5 minutes a day, whatever it might be. I think that message and that reinforcement of that message, that trying to get as much movement as possible, that's actually everyone's job, and all health professionals should be thinking about things like smoking, nutrition, activity, even without that specialized training. We have heard, and I totally understand that there can be some concerns around things like liability and risk. And, I've heard people say, I'm a mental health professional. If I tell someone go and do something and they injure themselves, what happens? And I think there's an opportunity there, and it's actually on the national bodies to sort of come together and provide some clear guidance and recommendation around this. So, yeah, in short, and there are lots of resources available for health and mental health professionals around how to have conversations about physical activity. And one of the things that everyone can do is even just think about measuring activity with some simple questions. And there's some really useful tools. One of them is called the Physical Activity Vital Sign. And it's 2 questions that basically just says, on how many days a week do you exercise for more than 30 minutes, or it's something like that. And then on how many days, and you sort of add those numbers together and it gives you minutes per week.
Okay.
And that can then be used against the WHO guidelines of 150 minutes a week. So you can either say someone you're meeting the guidelines or you're not. And that's a very crude, it's a start. But if we think about from a patient's perspective, if their psychologist is even just asking one question, how have you done any exercise this week? That can be a prompt that this is something important, something we should take seriously.
Okay, all right. So what I'm hearing is that as a psychologist, or we've got a lot of naturopaths and nutritionists listening to this podcast. So if somebody's presenting with, mental health condition and potentially some comorbid physical conditions, that's when probably a referral to an exercise physiologist might be particularly helpful for that individual. But other than that, we should all be recommending, exercise, physical activity, going for walks, those types of things is something that, we certainly can do. And but something that's a bit more intensive and potentially we need to kind of be aware of the physical limitations. That's when exercise physiology referral would be useful.
Yeah, absolutely. And the other thing I'd just add to that is also if you're sort of having these conversations and it's not getting anywhere, or there's a block, or someone needs additional support around that, I think that's when we can also think about referrals, because changing behaviour is hard. Engaging in exercise for the general population without any of these mental health issues is tricky. And so we can't just expect people to be able to make that change themselves. So that's where I think the EPs can play a role. Just like we need additional support with diet, we might need additional support with other things, that support is available.
Yep. So what happens if I have someone coming in and I do believe that exercise would be useful for them? They're not ready, so they're not ready for change. They're not, if I refer them to an EP, they wouldn't go. So there's that motivation issue, that there's that barrier associated with kind of starting exercise. What would you suggest to a practitioner around where to start with that client?
It's really tricky, and we see this even with our research. One of the really tricky things, and I'll bring this back to the Addi Moves program. One of the things that's really been effective there is the fact that we are located on site, because what we know is that particularly for some of the people that experience the greatest number of barriers, they may need to be introduced to us and our exercise physiologists multiple times before they actually come in for a session. So that first session could be that they're coming in and they actually just they say hello, or you might have a chat and they just see the space around them. And then the second session, they might come in and have a bit of a chat about what's happened that day or what they've done. So now I recognize that's not feasible for everyone, and that's not what happens in the real world. But I think the reality is that it does take repetition, and those stages of change, as you mentioned, people need to be introduced to this idea sometimes multiple times before they're willing to give it a shot, because often the people who will benefit the most are the least likely to want to engage in exercise. And so we've got to be creative and find different ways of introducing it and talking about it and promoting it. So if you're in another clinic, some of the other things that, if you don't have the luxury of that co-location, one of the things that I'd recommend, and this is quite specific, it's a relatively new area, but around goal setting. Traditionally there's been this push around SMART goals, and that being the only way of actually addressing complex behaviour change. But there's some great work happening at the moment led by Professor Christian Swan, looking at open goal setting as a different way of having these discussions about physical activity, particularly in the early stages when someone's, maybe not in that stage of change where they're willing. And so these open goals could be simply saying, like, can we, what can we think about doing more activity this week? Can we try and do more activity? Can we try and sit less a little bit this week? But having those conversations regularly can be really useful as a first step. But then also these referral pathways that we have, because we know that when we have these dedicated practitioners, we do get better outcomes, there's lower dropout, but it's about access as well, and that's tricky. So I think to summarise that, I'd say the first thing is measurement. So this idea about measuring activity, think about something like the vital sign, think about open goals, think about repetition of message, and also being patient with those referrals and how we might be able to link someone with the services available.
Yeah, great advice. I mean, I think you mentioned the stages of change, and I think that's an important model to think about, obviously pre-contemplation, contemplation, action. And often what I'm thinking is when I'm seeing someone, if you think about it, you go, okay, they're in the pre-contemplation stage, so they're not interested in changing. So, and you go, okay, they're in the pre-contemplation stage associated with exercise, but exercise is a very general term. But if we go, okay, there might be a pre-contemplation stage in terms of going to the gym, but they might be in the contemplation stage associated with regards to going for a walk or doing 5 sit-ups in the morning. Or so if we break it down even further, I mean, it's the same with diet. They may be definitely not wanting to change, stopping fast food intake. But if we think about, okay, well, what is it? What areas, specific behaviours are they willing to look at? And they might be willing to reduce their soft drink intake. So we just, as you mentioned, we just really kind of need to look at the individual behaviours, think about, well, what things can they start with? And it really sounds like with the research shows that doing any physical activity is going to be useful from a mental health perspective.
Yeah, I mean, you've summed it up really well. The only thing that I'd add to that is considering resistance training, other forms of activity, because too often when we think about exercise, we just think about going to the gym or going for a run or a walk. But there's a lot of evidence as well around strength-based exercises, and these can be done at home. They can be done with elastic bands. They can be done with body weight, in a very short period of time. And so those strength-based activities can be a nice pathway in as well.
And that's where I suppose seeing an EP would be useful, in terms of even developing a home exercise program that potentially people can do, which incorporate resistance bands and things like that. That's where I think, even from that perspective, could be really useful for many of our clients.
Definitely.
All right, brilliant. So, look, I came up with when I thought about this podcast, I came up with a whole range of questions, and I haven't got through many of them at all, because we could really just keep going on and on. But it's been great talking to you. I think the reality is that we really need to incorporate exercise as a component, as a preventative potentially for the development of mental health conditions, as potentially a preventative of the development of physical health conditions in people with mental health conditions, and then obviously as a adjunctive treatment for people with depression, anxiety, PTSD, even this more serious. I won't say serious, but because they're all important. But even the more severe conditions such as and chronic conditions like schizophrenia.
I think you've nailed it. Sums it up perfectly.
All right. Well, no, it's certainly been great talking to you, Simon, and keep up the work that you're doing. It's brilliant. The research that you're doing, the work that you're doing with refugees, and it's absolutely brilliant. And I certainly thank you for the work that you're doing.
Well, thanks very much, and thanks a lot for having me.
That's been an absolute pleasure. So thank you everyone for listening today. Don't forget that you can find all the show notes, transcripts and other resources from today's episode on the FX Medicine website. I'm Dr. Adrian Lopresti, and thanks for joining us. We'll see you next time.
This podcast is intended as healthcare practitioner education only, and it is not a substitute for medical advice, diagnosis, or treatment.
If you enjoyed this episode, please take a moment to give us a rating and review on Apple Podcasts, Spotify, or wherever you listen to FX Medicine, and share us with your family, friends, and colleagues.